Good morning, everybody. I'll be presenting CGR on behalf of Department of Radiodiagnosis on the role of percutaneous CD-guided biopsy in cavitary pulmonary lesions. As many times these cavitary lesions, the diagnosis is made with sputum and lavage, so they are not always referred to us. But sometimes when there is diagnostic dilemma and they could not achieve diagnosis by other means, then only they refer these cases to us. So we have done a retrospective study, and we'll be covering this session in these headings: introduction, material method, result, and discussion, and we'll be showing some representative cases followed by conclusion. And for the introduction and material method part, I will invite my junior resident, Dr. Sachin Gupta. Dr. Sachin, please come.
Good morning, everybody. Thank you, sir, for inviting me here. So I will be discussing introduction, material, and methods part. So introduction to a pulmonary cavity. Pulmonary cavity is a gas-filled area which is seen on imaging in the center of nodule, mass, or consolidation. It usually results from drainage of necrotic lesions via bronchial tree. It can be caused due to infectious, neoplastic, autoimmune causes. Mechanism of cavity formation. It can be divided into benign causes and malignant causes. Benign causes can further classified into suppurative necrosis, caseous necrosis, ischemic necrosis, and displacement of lung tissue by cystic structure. Suppurative necrosis includes pyogenic abscess. Caseous necrosis include tuberculosis. Ischemic necrosis include pulmonary infarction, and displacement of lung tissue can be done by hydrated cyst. Malignant causes can be due to primary causes or malignant metastasis. The malignant causes include treatment-related necrosis, internal cyst formation, internal desquamation of tumor cells. The diagnostic challenges in cavitary lung lesions. Because of their different etiologies of cavitary lesions, they can be present with overlapping radiological features. And from sputum or lavage, there are sometimes organism may not be detected, and if detected, it is difficult to ascertain whether it is contaminant or actual causative organism of the lesion. In non-infective causes, obtaining tissue from the lesion is the only way to reach the diagnosis. Now, percutaneous CT-guided needle biopsy. It is an established method for tissue specimen obtaining tissue specimen. It allows precise targeting of suspicious lesion, and it has high accuracy of around 80 to 90% to differentiate between benign and malignant nodule. It is safe and minimally invasive compared to other surgical options we have. Pathological and microbiological specimen can be obtained in the same sitting. So the main aim of our study is can be divided into primary objective and secondary objective. Primary objective is to study the diagnostic yield and safety profile of percutaneous core needle biopsy of cavitary lung lesions. And so our secondary objectives are to access spectrum of pathologies that are causing cavitary lesions in northern India. Another is to find out some CT features which can help us to differentiate between malignant causes and benign causes of cavity formation. Materials and methodology part. Our study design is retrospective cohort study. We are including all the adult patients who are more than 18 years and who are sent by different department to undergo PCNB for cavitary lung lesion from year 2010 and to 2024. The clinical, pathological, microbiological, and follow-up records are obtained from HIS, patient case sheets, and telephone calls. CT images and biopsy images are taken from radiological records, radiology records, and PACS. Our all procedures are done under 2 CT scanners that we have in our department, that is 64 slice and 128 slice and multi-detector CT. Mostly we have used 20 gauge coaxial biopsy needle set, and in some cases 18 gauge needle is used. Our all biopsies are performed under local anesthesia. So in this slide, we are trying to show the steps of the biopsy or biopsy procedure. First, we will ask the patient to lie down, mostly in prone position, and it also depends upon the smallest path of the lesion from thoracic wall. Now, we will take limited CT scan. Then we will see from the smallest and the best part from where there is less visceral involvement which can be there when we going through the our thoracic cavity to the lesion. Then we will, with the help of laser laser jet, we will mark the thoracic wall, and then we will mark the midpoint in the back with the help of any bony marker, mostly spinous process. We would mark the point of entry with the help of CT scan. We will decide where we can from where we can go in the lesion through the thoracic wall, and we will mark it with the help of distance which we have measured on CT scan. Now the area is cleaned and draped, and we will infiltrate the local anesthesia here, and we will use the biopsy needle as a marker to see whether we are in the right position and wrong. Now, sequentially, we will take multiple limited CT scans to go inside the lesion. And as we go inside the lesion, we will take the core tissue from the solid part or mostly the wall of the lesion, and multiple tissue cores were obtained. Around 6 to 10 tissue cores were obtained, mostly in formalin vial, and in case of suspected infection, the core also taken in normal saline and sent for culture. Mostly specimen is sent for histopathological examination. Post biopsy CT were done to check for any post procedural complication. Final diagnosis were established through response to treatment, either corroborative evidence from other investigation, follow-up or surgery if performed. Now, we will see the meaning of diagnostic yield. We will consider our procedure diagnostic if positive result is obtained from our biopsy procedure and no other further invasive diagnostic procedure and no alternate diagnosis is seen on subsequent follow-up. We will also consider our procedure yield positive if in case of it shows non-specific inflammatory result and patient subsequently shows improvement on antibiotics. We will consider our procedure non-diagnostic if it is inconclusive, it comes with necrosis only, and in case of non-specific inflammatory result, but other clinical diagnosis like TB fungal infection is made on further follow-up. We will consider our biopsy procedure discordant if diagnosis obtained from biopsy specimen proven incorrect subsequently. Basically, the diagnostic yield is the number of procedure giving diagnostic yield positive upon total procedure performed. Now, for the result, further part, I would like to invite the professor. Thank you, sir.
Thank you. Thank you, Dr. Sachin. So, coming to the result and discussion part, total 130 biopsy procedures were performed in 121 cavitary lesions from 2010 to April 2024, and the mean age was 51.5 years. And we had 81 males and 40 females, and in all procedures, tissue specimen could be performed. And in this slide, we will see that out of this 121 patient, we had a final diagnosis in 108 patients. In 13 patients, final diagnosis was not available because there was not details were not available, and we could not contact these patients. And in the patients where we had the final diagnosis, diagnostic PCNB results were obtained in 94 patients. In 13 patients, the results were non-diagnostic and discordant in one patient. So our diagnostic yield comes about 80.3%. In cases where we don't have the final diagnosis, the positive results by CT-guided biopsy were obtained in 10 patients, and inconclusive results were in 3. In 9 patients in whom we have performed a repeat biopsy, in 8 we could get a positive result. However, only in one patient, even after second biopsy, we could not get the final the result. So now, comparing our diagnostic yield with that of literature, actually there are many articles on biopsy of lung lesions, but cavitary lesion, if you see cavitary lesion specifically, I could get these 2 articles which talk specifically about the biopsy of the cavitary lesions. And in their series, our sample size was much larger than theirs. They had 53 and 30 cases in their study. So our result was comparable with that of Kiran Antawat et al. However, Shin Kei et al. Have reported a higher diagnostic yield. Now coming to the spectrum of cases which we have seen in our study, and also the final diagnosis. So the first column is the biopsy diagnosis. So the most common was tuberculosis, which were either reported as tuberculosis, and sometime only granulomatous was reported. However, most of these cases finally diagnosed as tuberculosis. Then the second common group was fungal infections, in which we had aspergillus. In some cases, aspergillus, diagnosis of aspergillosis with tuberculosis was made. Then we had mucormycosis, histoplasmosis, cryptococcosis, and in some cases, only fungal infection was reported. We had nocardia in 4 patients, bacterial abscess or infection in 3 cases. In 24 cases where the biopsy results gave only non-specific inflammatory result, out of these 15 patients actually responded to antibiotics, and a diagnosis of bacterial infection was made. However, in 9 patients, other diagnoses like tuberculosis, fungal colonization, non-tubercular mycobacteria, fungal infection. So these diagnoses were made in 9 patients. So most of our patients were benign, 73% of the cases, and mostly they were infections. About 27% of the cases were malignant, and squamous cell carcinoma was most common, followed by adenocarcinoma and metastasis in some cases. In 7 patients, only the report was necrosis. Only we could not achieve proper diagnosis, but on follow-up, one of these was tuberculosis. 2 patients were proven to be aspergillosis, and 2 bacterial infection. In 3 cases, the results were inconclusive. In this, 1 patient subsequently proved to be carcinoma lung, and other as tuberculosis. So this was our spectrum of cases. Now, comparing the spectrum of the cases in our study, we had mostly benign cases, and infections were most common actually. While in literature from West, we mostly have malignancies, which are more common, and benign lesions and infections are much less common. Now, in 13 cases, we had non-diagnostic results where we had only non-specific inflammatory picture, or there was necrosis only, or the specimen was inconclusive. And most of these cases subsequently proved to be tubercular or fungal. In 1 case only, we had the diagnosis of aspergillosis on histopathology. However, patient was given antifungal, but he did not respond, and then ATT was given, and then the patient responded. So in this was the only patient where a discordant result was obtained. Otherwise, we had either diagnostic result or in some cases non-diagnostic result. Now coming to the comorbidities, so about 60% of our patient had some form of comorbidity. And most common comorbidity was diabetes mellitus. And then we had renal disease, mostly in form of CKD. And also about 10% of our patients were renal transplant recipient. And some cases were having a primary malignancy, while some cases also had respiratory conditions, and some had somewhere on immunosuppression, like in rheumatoid arthritis on methotrexate. So the majority of our patients, if we see, they were either having diabetes mellitus, or they were transplant recipient, and or they were having kidney disease. Now coming to the cases where if we see the final diagnosis in a particular comorbidity, in patients having chronic renal disease, so tuberculosis was very common in 4 patients, followed by fungal infection in form of aspergillosis, mucor, bacterial infection, and nocardia, and in a few cases malignancy. While in renal transplant patients, mostly we have seen tuberculosis followed by fungal infection and nocardia. So tuberculosis and fungal infections, they were quite common in renal transplant patients. In diabetic patients, again, tuberculosis was the most common diagnosis, followed by bacterial infection, and in some cases fungal infection, and also malignancy in few. So these were the final diagnosis if you see in comorbidity categories. In literature also, lung cavities have been commonly reported in immunocompromised patients, whether they were HIV patients, or there were hematological malignancies, or they were transplant recipients. And in one study by Neyaz et al., in their study, they performed a study in solitary lung cavities, and they have seen that 21% of patients in their study were immunosuppressed. And they also concluded that active TB was 4 times more common in immunocompromised compared to that of immunocompetent. Coming to the complications, we had complications in 6 patients. And most of these complications were minor complications, which could be managed conservatively by oxygen supplementation, IV fluid, sometime injection Trenexa. And complications were in form of mild to moderate hemoptysis or minor pneumothorax, which does not require chest tube insertion. However, in one patient, we had a major complication where chest tube insertion was done, and this patient actually died subsequently. So some images of the complications. So in the first image, we can see there is a cavity lesion, and post biopsy, we can see there is a lot of alveolar hemorrhage. So alveolar hemorrhage can occur, but if it manifests as hemoptysis, then only it is considered significant. Or otherwise, if the patient is maintaining saturation and there is no hemoptysis, generally we are not worried. But if the patient starts having hemoptysis or its oxygen saturation falls down, then this is worrying. And the second complication is the air leakage into the pleural cavity as we puncture the pleura while we go into the lung. So these two are the common complications. Also, sometimes hemothorax happens because of the injury to the intercostal arteries. This is the patient where we had the major complications. So this patient was a renal transplant patient, which had a large mass-like lesion with large cavitation. And this patient developed opaque hemithorax and respiratory distress 48 hours after biopsy. Chest tube was inserted. However, this patient subsequently died due to sepsis. Biopsy diagnosis was non-specific inflammation, but one of his sputum report was showing methicillin-resistant coagulase negative staphylococci. So most likely, we think that probably we contaminated the pleural space as we were going into the lesion, and subsequently, due to infection into the pleural space, this patient worsened. However, that is the only way we can go into the lung without actually transgressing the pleura. We cannot go into the lung. Now, comparing our complication with that of literature, our complications were much less what have been reported in the literature. However, mostly these complications are minor. Major complications are mostly chest tube insertion due to pneumothorax. And these were seen in the series of Kiran Antawat in 10% and by Shinkei in 3%. One of the reasons that could be the reason of higher complication in their study because they were having a smaller lesion size. Our mean lesion size was 45 mm and their lesion size was smaller. So targeting a smaller lesion in the lung requires a lot of manipulation. Sometimes you have to repuncture the pleura. So the chances of pneumothorax and chances of hemoptysis, they increase if you are targeting smaller lesions, while larger lesions, it's easy to target. So this may be one reason of lower complication in our series. Now, regarding the CT scan findings in our patients, most of our patients were having a mass with cavitation, followed by nodule with cavitation, and then consolidation with cavitation, and most of the lesions were in upper lobe. As I mentioned, our mean lesion size was 45 mm, although we had the smaller lesion as well as very large lesion. So the range was from 1 centimeter to 13 centimeter. And the mean wall thickness was 11 mm, 11.9 mm. Again, the range was 1 to 30 mm. And we had 60 patients with a smooth inner cavity wall and irregular wall in 51 patients. In addition to the index lesion, many patients also had additional lesions like in form of another cavity or multiple cavities. Some patients also had consolidation or there were nodules in the lung, fibrotic areas, ground glass, emphysema, reticular thickening. Some had mediastinal or hilar node. 10 patients had pleural effusion. 1 had pericardial effusion. So these were associated findings. Like in this example, we have a large cavity lesion and there is another cavity and there are some nodules in the other lung. So this is how most of the patients presented to us. Now coming to the correlation of the CT features with that of final diagnosis. So we had these 3 types of cases. One was large area of consolidation with cavitation. The second was a mass-like lesion with cavitation, and third was a nodule with cavitation. Actually, the difference between mass and nodule is only the size. So less than 3 centimeter lesions are nodule, and larger than 3 centimeter lesions are masses. So we have observed that the nodular lesions with cavitation were more commonly having a benign or infective outcome, while the mass with cavitation and consolidation with cavitation lesions were both. They could be infective or malignant. While these smaller lesions with cavitation, they were more commonly to be infective. And if we see the lobe-wise final diagnosis, then the upper lobe lesions had more chances of being benign, while other lobes were having both benign and malignant. So probably this finding is due to the high incidence of tuberculosis in our country, as tubercular lesions have a predilection for upper lobes, and we had a lot of tuberculosis in our series. That is why our majority of the upper lobe lesions were infective or benign. Now coming to the mean lesion size or the diameter. So the benign group had a mean lesion size of 42 mm, while the malignant group had 54 mm. Although the standard deviation suggests that there was quite overlap between these lesion size. So generally, the smaller lesions were tend to be benign, and the larger lesions were more likely to be malignant. However, this association was not very much statistically strong, but in general, this was the observation. Now coming to the wall thickness, if we see in the benign group, the mean cavity wall thickness was 11 mm, while in the malignant group, the mean cavity wall thickness was 15 mm. So this finding was strongly suggestive of malignant outcomes. So a thicker wall, like in this case, was having more chances of turning out to be malignant. Other feature was the smoothness of the inner cavity wall. Like in the first image, we can see the wall of the lesion is quite smooth, while in the other, it's irregular. So a smooth wall lesion having a smooth inner wall were more chances of having benign or infective etiology, while the lesions which had irregular wall, they were either benign or malignant. And we also tried to correlate other additional findings, but they were not significantly associated in our series. In literature also, thicker cavity wall has been correlated with the malignant outcome. And things like consolidation and centri-acinar nodule, they have been more commonly associated with non-malignant lesions. And in irregular inner margin of the cavity wall has been suggested to be more common in malignant etiology. But there are some studies who say that wall thickness of a cavity alone is not a reliable indicator of a benign and or malignant etiology. Now, this slide, I'll be just showing the contribution of different results in our cases. Like we had 30 cases of tuberculosis. This is the finally diagnosed cases. And in these cases, if you see, in all cases, histopathology was performed and 17 cases were reported as granulomatous or tuberculosis. In 26 cases, gene export was performed and it was positive in 15 patients, while culture and microscopy were not positive that much. So gene export had a higher chances of giving a positive result. In nocardia cases, all these cases were picked up on fungal microscopy and culture. So we had 4 cases, and all these 4 cases, nocardia was picked up and reported in the fungal culture report. In the fungal infections, again, in 21 patients, histopathology was performed, and in 15 cases, we had a positive report, and it was reported as fungal infection. In 6 cases, it was either reported as non-specific inflammation necrosis. In 11 cases, microscopy and culture was performed, and in 7 and 8 cases respectively, they were reported as positive, where in few cases they were reported as negative. Now I'll be showing some representative cases. So this first case, this is a 55-year-old female. She does not have any comorbidity, and she presented with a large area of consolidation with cavitation. And obviously, when these patients come, they receive antibiotic, and if they don't respond, then only the clinician refer this patient for biopsy. And biopsy of this patient turned out to be adenocarcinoma. Another case, 64-year-old female, hypertensive patient, and she presented with a mass-like lesion with large area of cavitation. And if you see the inner wall, it was quite irregular, nodular. And this patient, the histopathology was squamous cell carcinoma. 46-year-old male, he had his history of carcinoma buccal mucosa. And on previous investigation, he was found to have multiple nodules and some were cavitary. So he had multiple lung nodules and some of them were cavitary, and the biopsy was done, and these were metastatic lesions. This case, a 36-year-old female, again, no comorbidity. She presented with a nodule in right lower lobe and with nodule with cavitation. And histopathology report was showing inflammatory picture, and the microscopy and gene expert were positive for tuberculosis. So this was a case of tuberculosis. However, TB culture was negative in this case. But we had microscopy and gene expert, both were positive for Mycobacterium tuberculosis. This case, a 35-year-old male, he's a renal transplant patient, and he presented with a mass-like lesion with cavitation, and there were also multiple cavitary nodules, some areas of the consolidation in other lungs. And histopathology was showing non-specific inflammatory picture, but the fungal microscopy and culture showed nocardia. So this was a case of nocardiosis. Case number 6. So this was a 49-year-old male. He had a history of coronary artery disease, and he presented with a mass-like lesion, which had a thick wall, but there was a fluid content. So this patient received some antibiotic with partial response, so diagnosis was not sure. Then biopsy was done, And histopathology picture was inflammatory. TB and fungal cultures were sent, which were negative. Bacterial culture was not sent in this case. And this patient responded to antibiotic, the lesion resolved, so a diagnosis of bacterial abscess was made. This patient, 60-year-old male, he's a chronic kidney disease patient. He was a chronic kidney disease patient, and he presented with a mass with cavitation, and there were internal soft tissue density within the cavity. And this finding is usually seen in fungal lesions, and biopsy was done, and this was proven to be a case of aspergillosis on both histopathology as well as on fungal culture. This is the last case, and he was a 84-year-old male. He had COPD with the hypertension, and in the CT we can see there was a large mass-like lesion with irregular inner cavity wall. There was a cavitation with irregular wall. So and he also had a lot of emphysema. So we thought probably this is some malignancy, and biopsy was done, but this case turned out to be mucormycosis. So these were the representative cases. Now I'll be talking about limitation. A limitation of our study is that this was the retrospective study. In 10 cases, we couldn't get the biopsy images, although we had other records of the patients. And another thing was that microbiology specimen, like in all cases, we sent histopathology, but TB culture, fungal culture, these were sent only when there was suspicion. And bacterial culture was sent only in 4 patients actually, because obtaining already we have to achieve a sample for 3 tests. So obtaining another samples become very difficult. So that is why usually we always do histopathology, and if possible, we also try to do bacterial and tubercular and fungal. But bacterial generally we leave because obtaining too much sample becomes difficult due to technical reasons. So coming to the conclusion, percutaneous CT-guided biopsy was able to achieve sample in most of cases from cavity lesion of the lung, and it allowed confident diagnosis in 80% of the patients. And with the 20-gauge biopsy needle, which we are using, overall complications are much less. They are 5%, and major complication in less than 1% of the patients. And most common comorbidity associated with cavity lung lesion in our setting is chronic kidney disease, renal transplant patient, and diabetes mellitus. And most of our cases were infective cases, with tuberculosis being most common, followed by fungal infection in form of Aspergillus, Mucor, and Cryptococcus. Then we had bacterial infection and also nocardia in some cases. However, in about 23% patient, we had malignancy, mostly squamous cell carcinoma, adenocarcinoma, and metastasis. So I would thank all of you, and a special thanks to Department of Pathology and Microbiology, because we only take out the specimen, and it is their hard work to give the diagnosis. And we would also like to thank Department of Pulmonary Medicine, Nephrology for referring these patients to us. Thank you.